It's a real pleasure to be able to talk to you today, and I'm going to talk to you about a topic that is both really, really simple and also really complicated, and I hope I can convey both halves of that as we go through. So my goal today is to have you understand urine. I really think the bladder and urine are really underrated. Like, everyone gets really excited about the SA node and the AV node, and all it does is just go squeeze, squeeze, squeeze. But the bladder is actually a lot more complicated than that, and we just don't give it any respect. So we'll talk about how urine gets where it needs to go. We'll talk about what is hydronephrosis. It's a term that we use, but actually a lot of people don't really understand what it even means. And when we actually care about it, which, spoiler alert, is a lot less often than you might think. And then we'll talk a little bit about reflux as one of the causes of hydronephrosis, as opposed to blockage, which is what most people think about first. So the kidney, of course, has a lot of functions, but I'm a plumber, and I only care about fluid and pipes, all right? So I care about the urine going down. That's it. You want to talk about renin-angiotensin, that's not my bag. That's somebody else, okay? And so what happens is you have the loop, countercurrent thing stuff, wave your hands, urine comes out the other end, and it goes into the calyces. So the calyces are these parts here that are shaped kind of like this. They're upturned cups, okay? They have sharp edges normally. You can see the sharp edges here. And then drains into the renal pelvis and right into the ureter. There are no valves. It's just an open passageway all the way down. And one thing that I think is super misleading right out the gate is that that picture that you see is true and also not true. So we draw that and we think of it as this open renal pelvis full of urine and this tube full of urine, but in reality, as fast as you make urine, it's getting sent right down to the bladder, such that there's actually no urine sitting in the ureter, and there's no urine sitting in the renal pelvis. So under normal circumstances, if you look with an ultrasound, you don't see fluid. You don't see a renal pelvis. You can't see the ureter on ultrasound normally because it's empty. So think of it like a fire hose that comes right off the truck, right? When there's no fluid going through it, it's collapsed and totally flat. And then when you start to put fluid through it, it becomes large. So right off the bat, that picture that you have in your mind is a little misleading because it doesn't actually look like that normally. So hydronephrosis, first off, let's just define it. It is a descriptive term that means that there is urine present in the renal pelvis that we don't normally see, all right? It is not a pathology, right? It is not a process. It is a description of what we see in the kidney itself. And we think of it as being a big problem because we think of it as being due to obstruction of the urinary tract, and often it is, but not always. And it doesn't always mean a thing. Sometimes hydronephrosis is totally benign, and it means nothing. And that can be really hard to convince people, but there's this thing on the ultrasound. Yes, I know, but it doesn't have any meaning, all right? So it can be benign or significant. It can be acute or chronic, and it will have a very different presentation depending on what's going on. So think of your ultrasound like a Polaroid picture, all right? Your ultrasound is a snapshot of the appearance of the kidneys at that moment, all right? And if you've looked at enough pictures, you make a guess about what's going on underneath based on your experience and the pictures you've seen before, but you don't actually know. The ultrasound can't actually tell you what's going on. So if I show you this picture of someone in scrubs, we generally are going to assume that they're a doctor or a nurse. But if I show this picture to a bunch of dog breeders, they're going to think that it's a dog groomer or a vet assistant or a vet, right? The picture is a snapshot, and we make inferences based on that appearance, based on our experience, that may or may not be true. We just don't actually know. So this is a normal ultrasound of a kidney, sort of longitudinally, and you can see how it maps to that picture, the anatomic picture we just drew. So you see these darker areas, which are the medullary pyramids. These are normal. And this is where the renal pelvis would be, but you don't see anything there. There's no actual fluid there. So normal outline, and then there's no dilated renal pelvis. You'll see your pyramids. This is a hydronephrotic kidney. This is about moderate hydronephrosis, and you don't see the medullary pyramids so well on this. You see them best in newborns. By the time you're older, they don't tend to show up quite as well as you're older. But you see this big black lake in the center that's got that same shape. Again, the calyces coming down to the renal pelvis. And you'll get this ultrasound report. Now here's where we get to the complicated part. So your ultrasound report is going to have a couple of things in it. Renal length. Honestly, don't really care. Like, people read me the newborn, like, that's a 4.5 centimeter kidney, whatever. There's a few places where we care. So if they have only one kidney, I care about that kidney's length because I need to make sure that kidney has what's called compensatory hypertrophy. It should be bigger than normal. So I care a lot about the renal length in that situation. I care about the renal length if there's a major discrepancy between the two sides and we don't know why, but I will tell you that 9 times out of 10 when that's seen, when you repeat the ultrasound, it was because there was a bowel gas over one end of the kidney and it's totally fine. So I don't get freaked out about that. I just like, all right, if you're really worried, repeat the ultrasound. So renal length doesn't really matter. We get the degree of hydronephrosis, and then here's the key one, the bladder. If you are looking at kidneys, please make sure they look at the bladder too. All right, especially in babies where we're doing our very first ultrasound, it should just be reflexively paired. And many radiology centers will reflexively do that, but not all. So you do actually often need to put in your order like kidneys and bladder, please, because we need to see the bladder. We need to see what's going on. And the main thing I care about in the bladder is wall thickness, particularly in babies. In older kids who have problems, I really care how much they can empty their bladder. So asking them to have a full bladder, take the pictures, and then send the kid to the toilet, bring them back, and take new pictures is very helpful. It really makes me crazy when people get referred to me for lower urinary tract symptoms and they have a kidney ultrasound with no bladder, because I have to just send them back to do it again because I don't really care in that setting what the kidneys look like. I need to know what the bladder is actually doing. Okay, so the first huge problem here is language. I have a big soapbox about how sloppy we are with language. I talk to the medical students repeatedly about it, how we use brand names and brand names that haven't existed in 10 years to describe catheters, to describe ports, to describe tubes. We're just really bad with language, and we are really bad with language here. So on your report, you are going to see a lot of different words, okay? Hydronephrosis versus hydroureteronephrosis is the first one, and it's the easiest. Hydronephrosis means that the kidney is enlarged, kidney is full of fluid. Hydroureteronephrosis means the kidney and the tube. All right, if they see a dilated ureter, it's both. All right, so they're not interchangeable words. My differential diagnosis and my plan of attack are very different if it's hydronephrosis versus hydroureteronephrosis. And typically you'll see mild, moderate, severe, but here we go. We'll start to see a bunch of other words. So pelvic caliectasis, pelviectasis, caliectasis, collecting system dilatation. These are all words that radiologists use at random. They pick them out of a bag, and every radiologist has a different set of words. My favorite being an ultrasound I got the other week in which the right side had mild pelvic calyceal dilatation and had mild pelvic caliectasis, and the other side had collecting system dilatation. And I'm like, excuse me while I take an aspirin and regret my choices in life, right? So every radiologist uses a different set of words, and you get this report back, and like, what does pelvic caliectasis mean? And I will tell you that most of the time, pelvic caliectasis, pelviectasis are words that are being used when it's not quite normal, but it's not quite bad. So usually that translates into mild hydronephrosis. But sometimes I find a radiologist who uses this word, and I pull up the pictures, and it is definitely not mild. So I hate this, and this is where I said it's complicated for you guys, because you get these reports, and what the heck does this mean? All right. In general, I would interpret this for the most part as being mild hydronephrosis, because typically if it's severe, they say that. Like severe hydronephrosis usually gets called, but all of these terms usually just mean they're hedge, a lot of times hedge. It's kind of normal, but there's like a tiny bit of fluid, and I don't want someone to come back at me and tell me that I missed something, so I'm going to use this word that totally kind of wiggle waggles around the thing, basically, is what this is going on. So you might say, but Kim, surely someone has found a grading system to actually make this standard, and indeed, not one, but two, right? There are several grading systems. This is the Society for Fetal Urology, and that's Onin's alternative grading. And sure, they're great, except that there are precisely 2 radiologists in the city of Baltimore that use this. Literally, when I get a report with one of these grading systems, I'm like, whoa, a zebra in the wild. So nobody actually uses them, right? But they do exist. It would be great. The other really nice thing, what we had in England, is everybody measured something called the AP diameter, the perineal pelvis diameter, literally across the length. That's super helpful. Nobody measures it here. I measure it myself on studies. It's annoying. So what do? I have to look at every picture. That's basically what it comes down to. I have to look at every study. And because I don't trust the reads, and you also don't know, like if my pediatric radiologists are reading it, I know them, I know the words they use, but all those places around, many times it's the adult radiologist reading them, it's different adult radiologists reading them, it's a different one today than it was 6 months ago who's using different choices of words, so is it different or not? I don't know. I look at all the pictures. And that's why I actually have access to most of the major radiology centers around. And the occasional time someone goes to someone that doesn't, I make them bring me a disc, which really annoys them, but I really have to see the pictures because it's just so inconsistent. So infant and child hydronephrosis basically is going to boil down to two categories. And it's going to boil down to obstruction and reflux. And I put obstruction in quotes because we use this term all the time, and it's another example of bad language, because 99 plus times out of 100, they're not obstructed. If they were obstructed, the kidney couldn't drain anything, right? They're actually stenotic. But it's such a vernacular that we use, UPJ obstruction, UVJ obstruction, and it's not actually quite true, right? It's not true at all usually. It's just a narrowing. But I will continue to use that term because that is sort of the popular, what you'll see. And then reflux is going to be the other major cause. And we're going to talk about reflux at the end, so I'm going to sort of take that and sit that out of this conversation. This is why we care about hydronephrosis, all right? Your kidneys are designed to generate urine under low pressures and peristalse it down to a very low pressure bladder. Your bladder's job is to hold urine at a low pressure until a socially appropriate time to pee. That's what it does. And a failure of any one of those components is a big problem, and that's a different lecture. We're not talking about bladder pathology. But the bladder should be low pressure. All of us should be storing, even you can go from 0 to half a liter of soda, and your bladder pressure should not change hardly at all, which again is amazing, right? It's not just like the pump, pump, pump. Like it's got to do this compliance thing. It's really cool. If for some reason that cannot happen, the kidney will try, right? The kidney will try to continue to make urine and push it against this pressure gradient. But at some point, actually 40 millimeters of mercury if you want to be precise, it starts quitting. The nephrons are like, I'm out. I'm not doing this. And they'll just start to disappear. Like nothing explosive happens. The kidney doesn't erupt. The nephrons just start to vanish over time. The kidney just thins out. Now, this is a very long process. So I don't want to leave anybody with the worry that, oh my goodness, we've got hydronephrosis and the kidney is going to thin out next week. Like this is many years in most cases. Like this is years and years and years of time. But this is why we worry. So think of this like the kitchen sink. This is the analogy I use for every patient in my office. I have a spiel for hydronephrosis, and this is what it is. So if you picture your kidney like the kitchen sink, if there's a clog in your kitchen sink drain and you turn the water on just a little bit, it'll go through just fine. But if you turn it on faster, it'll back up a bit until it reaches an equilibrium. If it's really bad, the sink will overflow, or in this case, the kidney will get damaged. But if it's not that bad, it often will reach an equilibrium where there's a few inches of water in the sink, but it's still draining. And that's the kidney. That's hydronephrosis in a nutshell for obstruction. The kidney is making urine. It can't quite drain enough because the pipe's a little too small to be adequate, and so it backs up a bit, and it kind of backs up a bit till the pressure sort of that stretched pelvis is enough to kind of balance and overcome. So the clinical symptoms depend on the presentation. So for infant hydronephrosis, this is chronic and it is painless. They have no idea. It can continue to progress. They will have no idea. Right? You can progress from a normal kidney to a completely dilated, blown out, gone kidney, and the child will never have a clue. Right? There is no symptomatology, basically, of chronic slow obstruction. However, if I acutely block your kidney, you will have opinions about it. All right? So kidney stone, sudden acute blockage of the kidney, considered as bad as labor pain by most people who have had both. All right? So acute obstruction is very, very, very painful, but chronic obstruction is not. And that leads you to the question the parents always ask is, well, what am I looking out for? And the answer is nothing. There's nothing. There's nothing for them to see, okay? There's absolutely nothing for them to see except a urinary tract infection. They cannot monitor this. The ultrasound follow-up is critical. And this is a problem, and we'll get back to this when we talk about the follow-up, because a lot of parents, the kid is fine. The kid is growing fine. Why do I have to spend my time or waste my time doing these ultrasounds and these boring visits with this woman who just says the ultrasound looks fine and we'll do it again in a year? Why do I have to do that? And it's because we can't tell. There's no way to tell on the outside. Or in blood work, of course, right? Everybody knows you have so much extra kidney function that I can take out 1.5 of your kidneys before your creatinine will really care. So you can blow out and destroy your entire left kidney, and as long as your right kidney is normal, your kidney function is just fine. So here are the two places where we usually in children see obstruction. We see it either at the ureteropelvic UPJ, up here where the kidney pelvis meets the ureter, or at the UVJ, which is down where the bladder meets the tube. 99 plus out of 100 times, it's one of these two places. Occasionally, you'll find something weird in the middle, but it's actually very rare. So it's usually one of these two places. This is developmental. Nobody did anything to cause this. People say, does it run in families? And the answer is yes and no. This is really common. It happens with no family background whatsoever, but there certainly are genetic processes that make you more likely to have a bit of a screw up in the tube plumbing, right? That's basically what it comes down to. So in this setting, you're going to have hydronephrosis only, right? This is plumbing. This is not rocket science. The fluid be backed up here. The kidney is going to be swollen. The tube's going to be tiny because not much is getting passed. On this side, though, you're going to have the hydroureteronephrosis. The blockage is here. The fluid has to back all the way up, so everything is going to be stretched out. All right? You don't get massive dilation of this kidney alone with no tube dilation if the blockage is down there. It just doesn't work like that. Okay, so again, there's nothing to monitor. There's nothing the parents can see. And so in reinforcing that these ultrasound follow-ups are important to make sure that things are okay. The only thing they can see is a UTI. And actually, I will tell you that not all of these pathologies make you more likely to have a UTI. In fact, most of them don't. If you have a mild unilateral UPJ obstruction, you actually have no reason to be more likely to get a UTI than any other human being. What you do have, though, is if you got the UTI and it gets into that obstructed kidney, you can have a much worse UTI than you would have otherwise. But actually, there's not really a reason why you would be higher risk for UTI. Okay, so here's the big question that's always happening out of the NICU, right, or the newborn nursery, is when do you need a VCUG? I will tell you that if you line up 10 pediatric urologists, you'll get 11 and a half answers for when you need a VCUG. So these are general guidelines, and individual providers may tell you something slightly different or may want a VCUG for reasons that you can't understand. And I will tell you that I have certainly ordered VCUGs because it smelled bad. And I couldn't give you any better reason than, like, I don't trust this particular child and I'm going to get this study because things, right? Sometimes you do that. The times in general where I'm going to recommend that the child has a VCUG is going to be whenever there's hydroureteronephrosis, right? So we're going to talk about reflux at the end, but think about it. If you have hydro from reflux, it's going from the bottom up. So what does it have? The tube has to dilate, the kidney has to dilate. You can't have a kidney dilation from reflux without the tube being dilated. So if I see dilation, I want a VCUG because I want to know if it's reflux or not. In a child with recurrent febrile UTIs, that's kind of a whole different talk, but that is an indication. You guys are probably familiar with the AP guidelines, which is one febrile UTI and a normal ultrasound you can hold off, but the second one you go, and certainly if you have an abnormal ultrasound, then you get one with the first one. And then a male infant with bilateral hydronephrosis, regardless of the severity, I'm going to get one. Now, there are other urologists that might say, well, it's really mild, so we'll just follow. We'll talk in a second about why I don't do that. But male infants with bilateral hydronephrosis are the critical ones. And like I said, you can do them for other reasons. Sometimes it just smells bad, and you just want one. But the question is, when is it urgent? Because actually, most of these kids don't need it in the hospital. They don't need it before they go home from the nursery. I don't care. If you have reflux, you don't need, if you can get one, great, we'll get the answer. But if you can't, that's fine. I would usually send them out on prophylaxis and just get the VCUG a few weeks later. There's really only one situation in which I will not sign off on a baby leaving the hospital without getting the VCUG. And that is when there is suspicion for posterior urethral valves. All right? I will make you transfer this kid. I do not care. This is not a situation in which you send them home and hope they come back in 2 weeks. So posterior urethral valves is a condition of boys. This does not happen in girls. Girls have a much shorter urethra. It sticks straight. It does not form this particular problem. It is a problem in which here, this is the prostatic urethra, you have these flaps. They're not fully obstructive because, of course, you would have Potter sequence and you would have in utero renal failure and terrible things would happen. They're not fully obstructive, but they cause an outlet resistance to flow that means that the bladder has to push super, super hard to get things to go through that. And the bladder is made of smooth muscle. And just like your bicep, if you decide to go on a regimen of bicep curls to make your bicep bigger, if your bladder has to work harder to get the urine out, the smooth muscle does the same thing. It hypertrophies. It gets more smooth muscle, bigger smooth muscle, more enthusiastic smooth muscle, and you go from this nice, soft, flappy bladder to this big, thick, ugly, trabeculated bladder because it's all the extra muscle trying to do its job. All right. This is a catastrophe to miss. All right. If you miss a unilateral hydronephrosis and they never come back and they show up to me at age 9 with a blown out kidney, I'll take the kidney out and they'll go about their merry, happy life. Whatever. All right. This is a catastrophe. If you miss this, the bladder continues to get worse, continues to get worse, continues to get worse, and by the time they present, typically, this is not recoverable, which means that they will generally have trouble. They will not be able, in many cases, to toilet train. They may already be going into renal failure from back pressure because the pressure that bladder has to generate gets transmitted backwards. Remember, the kidneys hate that. All right. This is a lifetime disaster, like clean intermittent catheterization, bladder augmentation, early kidney transplant kind of disaster. So this is why I have a super high threshold. Like if you have a boy with bilateral hydro, even if the bladder looks not bad, I'm going to get a VCG really soon. If the bladder is even the slightest bit off, you're getting it before you go home. All right. I trust no one. I trust no one to come back. All right. So this is the big flag exciting thing. So a kid with unilateral hydronephrosis, just send them to me. I'll deal with it in 4 to 6 weeks. I'll get the VCUG if they need it. It'll be fine. But this is the condition that we're worried about, that we absolutely must make the diagnosis. It is the only condition that is going to have a neonatal urologic surgery. Even if your kidney is horribly, horribly dilated and has terrible UPJ obstruction, I'm going to get a scan. We'll talk about a MAG3 scan at like 8 weeks of life, and then I'll operate on it. It's not going to happen in 2 days. I don't need to do it in 2 days. This has to be done right away. Right? This is a big deal. This is what it looks like over time. So this is a normal VCUG. This is a normal bladder. And I want you to please take a look at the joyous thing on the left here, which is a valves bladder. I'm not sure if that's actually a valves bladder or a neuropath, like a spina bifida bladder, but it's the exact same process that occurs. And this is, in fact, what happens in spina bifida as well. That bladder is not low pressure. It looks terrible. And that's not recoverable. Like I look at that, and that's a person who's going to have a bladder augmentation with the bowel and be on catheterization forever. We do not want that to happen. Now, that's not to say that it doesn't happen anyways. So you can have valves so bad that even though we treat it immediately and we're all on top of it, you still end up in that bucket. But there are definitely kids that could have avoided that if it hadn't been missed. And it's really tragic. I actually saw one just a few months ago. He's 5, and he still has nighttime and daytime accidents. And they'd seen a urologist somewhere who was like, oh, it's fine. He's too young. Just wait it out. And they got an ultrasound finally at 5 before sending him to me. And his kidneys are blown out and his bladder's blown out. And it's very bad. All right. So terror, yeah, things to scare you. All right, so we've got this baby. They've got some hydro. You listen to me, you're like, okay, I know that this isn't a panic situation. I'm going to send them to her to deal with. When am I going to follow them up? And when am I going to get the first ultrasound? So the correct answer to when you get the first ultrasound is a week or 2 after birth, because right at birth, you don't make a lot of urine. You haven't figured it out yet. And by a week or 2, you're making a lot of urine, all right? However, I'm going to tell you to get it before they go home. And I'm going to tell you to get it before they go home because I trust no one. All right? People are new parents. They're stressed out. This is not a priority. The kid is fine. It slips. All right? And you, speaking you as the primary care providers, are picking up this child from the NICU, and the mild, like, it's just not a priority necessarily, and things just sort of, they get a little bit lost. So I would much rather get the ultrasound while they're here then rely on them to come back in a week or 2. And oh, by the way, the insurance hasn't gone through and the kid doesn't have a registration yet and we can't book them and blah, 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 blah. All right. So 1 week is great, but before they go home is best. And so if the kid's going to be there for 3 days, I heartily endorse waiting until the 3rd day. Like the more you wait, the better the study is going to be. But I just don't trust anyone. And the other thing I'll see people do, this is a personal soapbox of mine, is that they will decide, oh, well, this patient is reliable. No. Okay, no. The assessment that someone is reliable is often a bit of a, sorry to say, a dog whistle for judgment of racial or socioeconomic status, and it is not true. There are just as many white, affluent people who will ignore the ultrasound as anyone else. So I do not judge people based on whether I think they're reliable. No one is reliable in my world. Sorry, okay? And then the question is, how often are we going to look? And this is where it's really a gestalt. So I actually looked at the literature on this. There's like a 25-page review article that I could summarize as everybody does their own thing. So I typically recommend 4 to 6 weeks. Now, to be honest with you, since Roger has retired, it might be stretching to 8 weeks. It's fine. It's not a big deal. Somewhere in that general picture is when we're going to get the first follow-up ultrasound. That will almost always be a little worse than it was at birth because of that urine situation. And so I tell parents that. Don't be worried. It's always a little bit worse, not always, but most of the time a little bit worse, and that's okay. But we're setting our new baseline for the future. And I use a Gestalt strategy here. So if it's really mild on the first and it's really mild on the second, I usually will just do 6 months. Like going any sooner isn't really going to matter. If it's really significant, I may go right to a MAG3 or I might get a 3-month scan. But anything sooner than 3 months is just too soon. You're not going to see any changes. And even 3 months is a really short interval follow-up. Like I don't normally do that because you just don't see when you line the pictures up. You can't see the subtle change. It's like watching your children grow, right? Every day you don't realize they grow, but if you mark it on the wall once every 6 months, you're like, oh wow, you grew 2 inches, right? But you can't see it when you're looking at it regularly. Same thing with the ultrasounds. And I'll follow it. Again, everybody makes this up. Everybody makes this up. They have a different strategy. If it resolves, I will typically either stop following or I will do one more year later to make sure it's resolved. Because remember, you can actually impact your ultrasound by your hydration status. So if somebody's really dehydrated the morning that they go for their ultrasound, it could actually look really good, and it's not actually any different. You're just a little bit less urinated. So I will sometimes get an extra one a year later just to be sure. So if you see that if you're seeing outpatients and you see me say it's normal, but I'm going to get another one, you're like, what is she doing? Again, I trust no one, so I often get one more, and if that's normal, we're done. Like, I don't need to look at it anymore. Or they get bad enough that I have to do something about it, or they're long-term stable, and here's where all the questions are, right? So if you have mild left hydronephrosis, you've had it for 5 years, it has looked the same every year, do we really need to do an annual ultrasound? Probably not. Should we just forget this ever happened? Probably not, right? And so it's a little unclear, and I often offer the patients the option of getting a MAG3 test that we'll talk about versus trying to do an ultrasound in 3 years, but then you introduce, will you remember, will they remember, will anyone remember, to get the scan down the road, which is a little dicey. Okay, so let's say your ultrasound is getting worse, right? Remember, I did say that the ultrasound is a snapshot, it's a Polaroid. It's not actually telling me anything functional. So I don't typically operate based on just the ultrasound. So if I need more information about how an obstructed kidney is working, I'm going to get a MAG3 scan. And what a MAG3 scan is, it's a nuclear medicine study that requires an IV. They put an IV in, they put a radio tracer in, and they can actually watch the kidneys take up the tracer into the kidney. So that's the first part, renal perfusion. And then they watch it create urine and measure this time it takes to drain it out of the kidney. So this is fantastic because it gives me functional information about how the kidney is working as well as how it's draining. One thing to understand about a MAG3 scan is that the function of the kidneys always adds up to 100% regardless of how bad the kidneys are. So it's going to be, if one kidney isn't working, the other kidney is 100%. If both kidneys are working equally, it's 50%. If both kidneys are terrible, they're both doing 50%. So sometimes you'll see patients with chronic renal disease where the parents are like, oh, his kidneys are great. They were 100% total on the MAG3. No, it's artifactually defined. Like whatever kidney function you have is the 100%. It's just divided between the two sides. And what I'm really looking at, I can't fix your perfusion. There's no real perfusion fix. I can fix your drainage, right? I'm a plumber. I care about the drainage. So I'm looking mostly at the halftime after Lasix. So they're in the middle of this test. They watch you make some urine. They watch you drain it for a bit. And then they hit you with a slug of Lasix. And I want to see the dye basically clear out of the kidneys. The halftime is less than 12 minutes, 10 to 12, depending. Somewhere in there is totally normal. More than 20 is an indication for surgery in general. And then the unwashed middle is indeterminate. You just have to keep watching with the ultrasounds. So this is very, very, very helpful in understanding what's actually going on with the kidney. It is not useful before about 2 months of age. Your kidneys your nephrons are immature. If you take terrible kidneys and do a MAG3 scan, they will drain very slowly. And it's actually not a plumbing problem. It's that they just can't, they don't have the oomph. The kidney just isn't making fast enough. And so this can be really hard to understand. If I have a kidney that's bad because it was blown out in infancy, and I fix it, and it still looks bad, and I get this MAG3 scan, and the drainage is a little pokey, but not terrible, is there a problem with my pipe, or is this kidney just, right? It's sometimes a difficult question to answer. So what do we do? For significant UPJ obstruction, we do a pyeloplasty, which is this operation. We basically cut out or open up the narrow spot, and we sew it back together nice and big. Plumbing, easy, all right? It's a very successful operation, about 95% successful. So I tell people 1 in 20 kids is still gonna have problems. Like point blank, 1 in 20 kids will still have problems, but most kids are gonna be fine. However, the critical point for parents that I make over and over and over again before I make incision is that this does not necessarily solve the hydronephrosis, all right? So if your kidney, think of your kidney as a balloon. If you buy a package of balloons and you open the package up and you pick the balloon up, the balloon is tiny and tight, right? And then you blow it up and it stretches out. When you deflate that balloon, you take the air out of it, does it go back to that same super tight appearance that it had when it came out of the package? It does not. And the kidney is just like that. So if the kidney has been stretched out over a long period of time and I let the air out of it, it will get better, but it doesn't go to normal in many cases. Sometimes it does. Like, I don't say it never does, but the bad kidneys are generally not. I did one last week with massive hydro, and I told the family point blank, when you get your follow-up ultrasound, the radiologist is going to tell you there's severe hydronephrosis, because it really upsets the parents, right? You did this operation for severe hydronephrosis, and then they get their follow-up study, and of course nowadays in the age of people getting all their records before you even see it, right? Before you even see it, the parents are like, it's still severe, the surgery has failed. And then you get on the phone with them and you're like, I love it, it looks great. And they're like, you've lost your mind. Like, what are you talking about? So I'm very careful to set that expectation that the kidney is not gonna look normal, right? And this is where the ultrasound as a Polaroid fails you, because now, this is now a post-surgery kidney, and I have no idea if that hydronephrosis is because it's just boggy and floppy because it's boggy and floppy, or if there's actually a problem. Right? That's where my job gets much more difficult. For UVJ obstruction, we do one of two things, either dilate or stent endoscopically, or ureteral reimplantation. We just need to cut out the narrow spot and stick it back in. It's all plumbing. Okay, so that was obstruction. We're going to flip page a little bit to reflux. So this is the other reason you get hydronephrosis, and this is where the bladder is squeezing urine back, and it's the pressure from the bladder that has stretched up the tubes and stretched up the kidneys. So the way you're plumbed, your pipe goes into your ureter goes into your bladder as a one-way valve. Right? It's a really neat, clever design anatomically. Okay, so the ureter is supposed to enter the bladder at a super steep angle that allows, when the bladder squeezes, the two parts of the muscle wall squish together and close the pipe. All right, that's the whole point. And it's very, very, very effective. But a lot of kids during development, it doesn't come in at quite the steep enough angle. It comes in a little bit more straight in, and that's the appearance you now have. And so you can see that when the muscle squeezes, there's nothing to close the hole, so urine goes back up. All right. The kidney doesn't care that you have reflux. The kidney does not care where the urine came from. If the urine came from back from the bladder or from it doesn't matter. It's urine. What the kidney cares about, though, is that this is a conduit for bacteria to get into the kidney. So you could have a lifetime of reflux, but if you never get a UTI, who cares? All right? But if you get bacteria into the bladder, they will get ejected back into the kidney, and you will get a significant infection very quickly. And that will cause renal scarring over time. All right, and every piece of renal scarring is a little bit of loss of nephrons and a little bit higher risk of hypertension down the road, and it eventually leads to significant problems. So this is how you grade reflux on a VCUG, 1 to 5. All right, the key thing to know here is that 1 and 2 will not show up on an ultrasound. The tube is not dilated. The kidney is not dilated. The ultrasound will be normal. And 3, actually, so often you don't see on an ultrasound as well. 4 and 5 you're going to see on an ultrasound. So I can tell you, if you come to me with febrile UTIs and a normal ultrasound, I can tell you with some degree of certainty that you may have reflux, but you probably do not have severe reflux, right? You probably have mild to moderate reflux. So that's an important point, that the ultrasound, this is where the whole fight happened many years ago when the AAP came out with the rule that you should only do a VCUG after the second UTI, and the urology community lost every bit of their mind, because the urology community is like, guys, like you're missing reflux. And I think in the end they've kind of lost that argument. Although many urologists will still send you after the first febrile UTI. They still don't believe it. All right, so it is important to know that. So what do we do to treat reflux? Well, the good news is, as you grow and your bladder gets bigger and everything gets bigger, this tends to go away. The bladder itself will grow and the angle will get a little bit better, and then all of a sudden it's opposing itself and the reflux disappears. And it's actually very likely for the reflux to disappear if it's mild to moderate. Very likely. It is less likely for severe reflux, but not impossible. I have several patients that I was laying crepe from day one about your grade 5 reflux, and someday we're going to have to operate on this. And there was one even that I did a pre-op VCUG for just because you should. It had been a while, and it had disappeared. So the parent came upstairs and I was like, well, so I have good news for you. Yeah, we don't need the surgery that I've been talking about for 5 years, right? Cool. So it can go away in severe reflux, but it is much less likely to do so. And I'm talking about primary reflux, to be clear. So this is reflux that occurs because of the mechanisms I'm talking about. Secondary reflux is when you get it because your bladder is destroying from the posterior urethral valve. I'm not talking about that. That's a totally different animal. So many years ago in the 80s, we used to treat all the reflux. Everybody got the reflux treated. Roger Voigt will tell you that he did thousands of reimplantations in the 80s because if you had reflux, you got surgery. And over the last 40 years, we've realized that we have been way over-treating like everybody, okay? So nowadays, reflux surgery is actually pretty rare. We don't do it that often. So the general recommendation is going to be antibiotic prophylaxis, so low dose once at night, long-term until you outgrow your reflux, all right? I tell people, please do it at night. It does not actually matter before toilet training, but it does after toilet training because you hold your urine the longest at night. You want the maximum concentration of your antibiotic to be in at night, so it does actually matter. Prefer to do it at night. And it used to be that everybody with reflux got put on antibiotic prophylaxis, but we are continuing to taper down how much we treat reflux a lot. And so nowadays, before toilet training, if you have a febrile UTI and a history of reflux, you're going to be asked to go on prophylaxis. If you have high-grade reflux and no infections, you're still going to be put on prophylaxis. So this would suggest that an infant with low-grade reflux, you might not need prophylaxis. That may be true, but I'm going to tell you that I'm going to offer it to everybody because a bad pyelo in an infant that lands you in the hospital is not cool, all right? So again, you can choose not to for one or two. One, we generally don't treat at all. Like you rarely even see one on a VCUG because we're not usually don't see it. But you can consider not treating it, but I would say with especially small infants, I generally would. After toilet training, the number one thing to know is does this kid have bowel and bladder dysfunction, right? So if you come to me with reflux and you pee twice a day and you poop once a week, I'm not offering you surgery. You've got to fix yourself first, okay? You've got to learn to go to the toilet every 3 hours. You got to get on some laxatives. You got to poop every day because having your bladder be dysfunctional increases the pressures in your bladder and it just makes you more likely your surgery to fail and your reflux to not get better. So the real treatment, you've got to work on their bowel and bladder habits. If they don't have bad bowel and bladder habits and they're having febrile UTIs with reflux, these are the kids that get surgery. Okay? If I can't fix anything about what you're doing and your reflux won't go away and you get breakthrough infections, congratulations, you bought yourself a reimplantation. But otherwise, the treatment generally is bowel and bladder dysfunction, bowel and bladder dysfunction, bowel and bladder dysfunction, and all of your patients are constipated. Sorry to tell you, even when they tell you they poop every day, they're pretty much all constipated. So really aggressive management is really important here. So coming back to infants, this is why if they have hydronephrosis, which suggests they could have high-grade reflux or they could have a UVJ obstruction, we don't know. What I'm generally going to recommend is put them on prophylaxis and I'll get a VCUG in a couple of weeks. There's no real reason that we need to rush to get that. It doesn't really matter as long as they're on prophylaxis. If they have UVJ obstruction, meaning there's no reflux on a VCUG, I'll stop the prophylaxis because nothing's refluxing. But that saves you from having to get a VCUG. The kid should go home on a Saturday. Are you going to really keep them until Monday for that VCUG? No, there's no reason to do that at all. All right, so that is sort of a whirlwind tour through hydronephrosis and reflux. Thank you very much. Thank you.